Okay, we are going to talk about musculoskeletal disorders. Scoliosis is our first case study or application exercise. Let's talk a little bit about scoliosis before we get into the application exercise. Onset is typically pre-adolescent growth spurt around the age of 10 is typically when we start screening, so this is typically when we see it. Signs and symptoms: forward bend of the rib hump, so there's going to be asymmetry in the abdomen. Uneven shoulder height because of that decreased range of motion in the abdomen, and you'll see that the clothes don't fit correctly. They'll hang longer on one side than the other. Typically, it's diagnosed, the child bends forward, 90-degree angle, and they're typically just in their undergarments or a pair of shorts, so we can see that curvature of the spine. If we note any curvature in the spine, we'll send them either for an X-ray or a MRI. All right, let's get into the case study, and then I'll kind of talk about some other things as well with scoliosis. So we have a 15-year-old adolescent. They're admitted to the orthopedic unit for Harrington rod instrumentation due to a 45-degree curvature of the spine. The adolescent is angry and states that she will look like a freak. Her mother verbalizes concerns about her daughter having to go to the ICU following the surgery. Okay, so she's going to get some instrumentation put to help in her spine to help that curvature. Some spinal fusions with hardware will require a cast for 9 months after. So it just depends on the severity of the scoliosis, what they're going to do. All right, for our 15-year-old here, what should the nurse teach the adolescent and mother regarding post-op care? All right, so she's going to the PICU after this surgery. So again, you know, what are you thinking about here? Hopefully you're thinking about PCA. You're going to let them know that you're going to do dressing checks, neuro checks, vital signs, positioning every 2 hours. The way we will position them is log rolling. They're basically going to be laying flat. Some of the other things that you're thinking of as a nurse is your post-op care and your assessments. Wound check. And what are you checking that wound for in the first 24 hours? You're checking it for bleeding. You're thinking hypovolemia. If they are hypovolemic because they just had surgery, if you're not seeing outward bleeding, they could be bleeding internally. So again, you'll see some vital sign changes with that hypovolemia. So think about what, you know, your blood pressure decreases, your heart rate increases to compensate. You're going to check your neurovascular assessment, so your circulation, neuro checks. Probably is going to come back with a Foley. I'd want to let her know that. And when they come back with a Foley, you're thinking of INO. And again, your INO would be an indicator of hypovolemia. If I'm not making any urine, my kidneys aren't being perfused. So you would think of that cascade as well. You would talk to them about DVT prophylaxis. She could come back with SCDs, I would expect, and then incentive spirometry as well. And typically on day 1, they measure for a new brace, and on day 2, she's out of bed with PT. All right, oh, look, I think I already answered number 2 for you. Which of the following are priority assessments for this adolescent admitted to the PICU from the OR following surgery? Select all that apply. All right, so I'll let you guys take a look at that. What do you think your priority assessments are? My priority assessments are B, C, E, and F. Again, when they're just coming to the PICU, of course, I'm assessing the wound. I'm not really assessing the wound for infection right after surgery. Remember, we always talk about it's going to take a few days for infection to start. Typically, 99% of the cases. Obviously, we do want them to eat a balanced diet, but that's not my main concern the day after surgery. But, you know, I'll worry about those things as we go on. But those 4 things are my priority in the PICU. What should the nurse monitor to assess neurovascular status in the post-op period? I already told you guys what a neurovascular assessment was, so I will go ahead and let you answer that question. All right, number 4, what can the nurse do to promote normal development and compliance during post-operative care? Help with range of motion exercise, encourage self-care such as washing, eating, age-appropriate activities, contact with friends and family, encourage family to be involved in patient care. Again, so just make sure you guys remember with anything we've talked about so far, the main goal of everything is to promote optimal functioning, optimal independence for what they can do. And I know that some of you may not have the opportunity to see kids in the clinical setting, but you will definitely, if you work in peds, you'll see kids that are sitting in bed and, can you hand me my water? No, I think you can reach it yourself. So again, just kind of make sure they're doing the things that they can for themselves. All right, that was my last question on the case study. Let me tell you a few other things with scoliosis. Before surgery, there are some treatments options such as bracing. Some of the issues with bracing is it doesn't correct the curvature, it stabilizes it until growth is complete. Bracing is for mild curvature, 10 to 20 degrees. They'll be in that brace for 18 to 23 hours a day. Adjust every 3 months for growth and development. And we usually, once they get a little bit older, they've had the brace for a while, we can gradually wean them to wearing the brace just at night. There is another option to bracing. It's an orthopedic jacket, but that is a little bit more costly. Some of your issues with bracing would be skin breakdown, how you could accommodate those. They could wear a t-shirt under their brace and make sure they are keeping their hygiene up. We need to make sure we are keeping them free from injury. They should avoid slippery surfaces, use a handrail, no horseback riding, no contact sports. Make sure when they get the brace that they're practicing sitting, practicing standing with that brace on, and position changes. It will be a little bit different for them. So we want to make sure that they're comfortable with that brace. Some self-image issues with, again, it's the adolescent, so we know self-image issues are big in this age range. And again, with scoliosis, if I'm wearing a brace, I'm going to look different from everybody else. And some of the issues you got to worry about are curiosity of peers, because obviously when somebody has a brace on, most people kind of just stop and stare because it's not something that we're used to seeing. We got to think about their development of sexuality. They don't want to be seen as unattractive. They're afraid that they won't be accepted. And again, some of the things we can do to help combat those issues, you know, they can wear concealing clothes. I know most adolescents don't want to wear concealing clothes, but they can. They can hide the brace. They can get creative. But the most important thing is we need to stress the importance of wearing this brace. And if they don't, if they take it off when they leave the house, which they could very well do, what's going to be the outcome of that if that would happen? All right. The last case study or application exercise I want to talk about is rheumatoid arthritis. Let me hop around until I find it. I feel like it's on a different one. Yep, here we go. Okay. So we've got rheumatoid arthritis. Let's see here. What do I want to say before we start this? Okay. Rheumatoid arthritis is autoimmune in nature. It is a systemic disorder of connective tissues and joints. So you'll see a lot of joint stiffness, a lot of joint pain. When do you guys think joint pain and stiffness is worse? It's typically worse in the morning when they wake up. How we diagnose rheumatoid arthritis, we diagnose it because they have an elevated WBC, they have an elevated SED-rite, they're positive for the rheumatoid factor. Now the rheumatoid factor may or may not be present. On an x-ray, if it's early rheumatoid arthritis, you'll see a widening of the joint spaces. X-ray, as the disease progresses in its later stages, you'll see those joint spaces narrowing. Symptoms must be present for 6 weeks or more for diagnostic purposes. The issues with RA: impaired physical mobility, pain, self-care, and knowledge deficits. We'll work through some of those issues with the case study, And then when it comes to self-care, we can use assistive devices if that's appropriate for them. We would assist if they're unable to perform independently. We could put splints on. Obviously, we're wanting them to rest. And again, the overall goal is for them to be as independent as possible. All right, let's take a peek here at the case study. We got a child with RA. They're presenting to the ED with acute inflammation of certain joints. She tells the nurse that she's been feeling weak and has had difficulty maintaining her ADLs. During exam, the nurse notes her wrist and knees are red, swollen, and tender with limited movement. Identify assessment data needed during the course of treatment to help determine this child's progress and readiness to be discharged. Obviously, we would be continually assessing those affective joints. Hopefully the stiffness is going down. Hopefully the swelling is going down. We're seeing increased range of motion, decreased warmth to those joints. They're not tender, they're not painful. You want to assess for systemic signs as well. And then, what's the relief of pain? What's their knowledge of their meds and their treatments? They should progress to being independent with ADL. I said those systemic signs and symptoms, those would be considered fever, malaise, myalgia, hepatosplenomegaly, rash, pleuritis, pericarditis. You could see those things with RA as well. The child reports pain during her PT exercises and states she doesn't want to go back to PT again. Suggest an intervention to solve this problem. All right, so we could medicate with morphine prior to PT. I don't think that's the best option because they're going to be sleepy. Use ice packs before PT to decrease inflammation. Again, ice is not appropriate here. The appropriate measure would be C, to use heat of some sort. A lot of times, what we could do with these kids, if they know they're going to PT, we could give them pain medication an hour before they go. And when these kids are home, we do that as well. We wake them up an hour before they actually have to get up. We medicate them for pain. They go back to bed, and then you wake them up for their day. Other pain modalities, splints, rest, and again, avoid excessive weight gain. That will put more pressure on those joints. All right, what measures can be taken to decrease pain and prevent deformity during sleep? I kind of already said some of these things. Splints on while sleeping, a firm mattress can help, a heated bed, water bed if they can get that, electric blankets, lay flat and alternate with prone, no pillows, joints extended are some of the things that we could do there. And then describe ways to meet the child's developmental needs. We talked about this before. Give them choices. We could give these kids chores around the house to help out and keep them active. These kids we want them to go to school. They go to school regularly, but sometimes their school day could be shortened. There are support groups, and there are camps for these kids as well. What are we doing to maintain joint function when there's pain? Simple isometric exercises, play, active as possible without stressing joints. So when they're in pain, we're doing just simple isometric exercises if they can tolerate that. When they're not in pain, what are we doing to maintain joint function? Again, keeping them as active as possible without stressing joints. Play is involved here as well. All right, I think that's all I have on the case study. I'll continue lecturing on RA with your slides, but I'm going to start a new video for that, or new recording.